Hey everyone, thanks so much for joining me on the Slice of Healthcare podcast. I'm your host, Jared Taylor. Today I'm joined by Dr. Emad Rizk, the chairman and CEO at Cotiviti. How are you today?
I'm well, Jared. Thank you for having me. Good afternoon.
Excited for us to chat. We were just saying you're the first Egyptian we've had on the Slice of Healthcare podcast, and you were telling me you're usually the first Egyptian on a lot of things. So I thought that was pretty funny.
It's a combination. It's a Mediterranean combination of Egyptian and Lebanese and that whole Mediterranean basin. But been here for a long time now.
Well, we're excited to have you on the podcast to talk about a few things. We're going to kick things off, if it's okay, if you can tell the audience a little bit about your background, and then we will go into basically what our audience has really become accustomed to, the why, how, what of your company, and a couple questions that I have about the space that you're in.
That'd be great. We're probably not going to spend a whole lot of time on the background. There are more important things to discuss, but I've been in the healthcare industry for a very long time, as you can see by my bio. I've been both on the provider side and on the payer side, and on the pharma side. So I have a good sort of 360 view of healthcare. Understand the payer side of healthcare and how they need to work with providers, and just been in the healthcare space for over 25 years.
Well, thank you for the quick intro. And you're right. Like, I just always ask that so the audience gets a sense of who you are, but they'll have links to you, and they can also learn some more about you from there.
If we just skip that part, to be honest with you.
Yeah, that's completely fine.
Just,
Yeah,
because it's a they can have it. I mean, I'll sneak it in there, and if you can, it doesn't add much to it. If it's all right with you, Jared.
Yeah, no, absolutely.
We'll
skip through it.
Just like kind of like you're talking about yourself.
Let's let's skip over to the why, how, what of Cotiviti, and then we'll go into some of the questions that we have today. So whenever you're ready, we'd love to kind of hear it from you, the why, how, and what of your company.
Sure. Should we start with the why and how and
That'd be great.
what? So why? Healthcare, as you know, is a very complex industry. And when you think of healthcare, because it's so complex, I always like to think of it in terms of these 4 to 5 different verticals. One vertical is payment, the appropriate payment for services rendered, by payers to providers or provider of services. The second one is risk assessment and risk stratification, understanding the level of risk and the risk burden, something that we've become very all accustomed to over the past couple of years with COVID. Third pillar is quality. And what is the quality of care? We also we hear a lot about that. How do you measure the quality of care and the quality of care that's rendered? Fourth pillar, which is a little bit tied to the fifth, is really reaching out to the consumers, making sure that you're engaging your consumer, engaging the patient or engaging the member, depending on who's actually engaging you. And then fifth is really the network, the providers and the hospital systems and the home health, all of those providers, and how those providers are, coordinate care across the continuum of care. So that is the why we exist. In terms of where we play, we probably play in all 5 of those pillars. Frankly, we're one of the largest payers. So we get approximately somewhere between 800 to about $1 trillion worth of claims per year that we process through our engine, and we make sure that is appropriately paid for by the payers to the providers. On the risk side, we also get a lot of data, and we mostly get information from the providers and the charts, and then we assess and stratify the risk. Patients that have various diseases, 1 disease, 2 disease, 3 disease, we stratify it, and we help understand the population that's at risk. Quality, we have a number of tools like HEDIS and STARS that you've heard about, where we help our clients, whether they're providers or they're payers, to be able to measure. There's actually guidance in terms of measuring how someone is providing quality care based on certain quality metrics. Fourth, we also have a tool, used to be called an old ELISA tool, and that is where we actually reach out to our consumers and make sure that they understand that they have an appointment, and you've received many of those, and your audience has received them, or also for closing gaps in care. And in terms of the network or the providers, we just have a large database understanding. So for you, Jared, who your physician is, who your specialists are. So in case we ever need information, we can access it through them and through you.
Appreciate that. The why, how, what. It's something I always like to focus on. I did not create that. I got that from Simon Sinek in his book, and what he focuses on when people care about what a company's doing, right? Why they're doing it, how they're doing it, and what they exactly do. So appreciate that. We're going to shift focus to another why for you. And my question for you is, why is it now more important than ever for payers to focus on payment accuracy?
Well, it's payment accuracy it's a great question, and I'd like to dissect that question into two pieces. The first is pre-COVID, and why even pre-COVID it was important for payment, because we spend about 3.5 trillion, circa 3.5 trillion dollars in healthcare. About $800 billion of that, Jared, is some level of inappropriate payments, whether it's due to administrative complexity, whether it's overpayment, like what happens in Medicare and in Medicaid, over 50 billion and over 80 billion in each one of those subsequent, and then also in the commercial space. So there's a lot of overpayment. I like to say that it's overpayment or over complexity or over administrative processes. There's also a little bit that's basically just either waste or abusive behavior. And so when you have about 800 billion to $1 trillion, which is a third of your entire spend going into non-value added activity, that really does not focus on patient care. And when we're thinking about high quality patient care, everybody getting access to health, we can't afford to lose a third of everything we're spending on waste and fraud and payment. So prior to prior to COVID, that was an issue. After COVID, right now, because of a lot of the new regulations and additions and COVID bypasses, because right now, when someone gets COVID, we kind of bypass them in terms of the payment. That has opened up the door for a little bit more abuse. Where someone could say you could go in for, I'm not saying that it does occur, but there would be like two examples of that. Could be where someone doesn't actually have COVID but is suspected of having COVID, but basically they're giving a diagnosis of COVID, and then a million other services or hundreds of other services are done under that umbrella of COVID. So it does not go through the rigorous review just because of that COVID oversight. The second thing is, as you know, there's been a lot of telehealth and a great deal of just Zoom calls and everything. And then there are levels of care. When you go to a doctor, sometimes they spend 5 minutes with you, 10 minutes, 20 minutes, 30 minutes. That level of care, level 1, level 2, level 3, level 4, level 5, is also dependent on the complexity of you as a patient. So a lot of times right now, when people are just doing Zoom calls, they could be charging level 4, level 5, and that's wasteful dollars, and it's really a 5-minute call, and they're doing that. So more than ever, because of the regulation and because the really the just centurion changes that have occurred, with COVID, it has opened up the door for some bad behavior.
Yeah, it's I've always been curious about that question. I want to make sure I asked it, and I want to kind of tailor off that a little bit. When we talk payment accuracy, there's really two types, right? There's prospective and retrospective accuracy. For the audience, some may know what that means, but for those that don't, can you kind of discuss a couple of the differences? And I guess if you can quickly go through the pros and cons of each included in those descriptions, that'd be super helpful.
You ask very big questions and you want very small answers.
I know. I'm sorry.
No,
It's
don't be sorry. They're very big, so it's sometimes a little bit hard to kind of shrink them down into sound bites, but you have to. So obviously, when we say prospective and retrospective, another two words that we can use to qualify those is prepay and postpay. So prepay means that we review the claim and make sure that the claim is accurate prior to the payment to the provider by the payer. Postpay is that you already have paid it, but then receive data after the services were rendered and after the payment that makes you, like, whether it's eligibility or specific services that you want to verify did occur, and then you actually go back and recover the extra amount that was paid. Does that make sense? So that's the definitional prepay and postpay. Obviously, in prepay, you have to make very quick decisions because there are regulations on how fast the payers have to pay to the providers. So we have an actually very sophisticated engine. It's one of the most sophisticated in the country, where we could review millions and millions and even billions of it within milliseconds. And it's about, hundreds of millions of different code lines that we have to review, that we leverage AI, we leverage natural language processing, very sophisticated systems where we get all of this, and we basically, through algorithmic looks and understanding, we could verify whether or not some care did occur and that we're paying appropriately with about 99% accuracy. I mean, this has been fully proven. What's good about that is that you actually change the payment prior to paying it. So in other words, a claim comes in, it's for $10,000. It is adjusted to $9,500. The correct payment's done. And that occurs in milliseconds, as I said, and hundreds of millions of transactions per day. So that's on the prepayment side. On the postpayment side, you start to look at the data, and we start to look at the charts, and we start to understand, well, you did these three different services during the same time frame that it took one. And although we paid it because you kind of said you did, we came back and we found out that you actually can't do that. Could you please send us the chart so we could verify that? And that usually takes from weeks to sometimes months to be able to do that. The problem with that is much more intrusive into the providers. And it's also a lot of labor intensive. And a lot of times you're actually going back to providers and saying, we've overpaid you. We have to either recover or we have to actually offset it in future payments. So the preferential process for everybody involved, think about it. If you went to buy something in a store and then you bought it for, let's say $10 or something, and then all of a sudden the store calls you back and say, you paid us 10, you really owed us 15 after you've left. The recovery also becomes a little bit less because they're not necessarily have to do that. So what our customers really want is to move as much of the post pay into prepay.
Interesting. Yeah, it's thank you for breaking it down for us too. Really appreciate that. It was something I was curious about. It's been something I've been hearing more about, so I had to make sure, since we had you on today, that was one of the things that we asked. As we start to kind of wrap up here, we usually keep these things 15 minutes or less is usually our focus. My last question for you is really what's next for Cotiviti?
Yeah. Well, that one conversation right now that we talked about in terms of moving a lot of the post pay into prepay, we're in the beginning of that. We're the leader in it because we obviously, as a large organization, we have both prepay and post pay. So step one is to move and start to increase. We're now beginning to, isolate about 10, 15, 20% of the post pay amount, moving it into prepay. Where we would like that in terms of what's next for us, it would be good to get to 50%, 60% of everything in post pay and have enough intelligence to be able to get it in prepay. So that would be a huge value for our the healthcare industry, frankly, considering our footprint in the healthcare industry. The second thing is really leveraging data that we get through all of these four pillars. So we get data through payment. We also get data, as I said, through risk. We get data through quality. We also get data through reaching out to consumers. Every time we interact with the providers and the consumers, we collect data. That data, if we can be able to be intelligent in creating one single centralized repository of data. So instead of constantly going back and re-looking at the data, and how many times have you been to the doctor and you have to answer the same questions over again? And if you went someplace else in the country, they don't have your record. What if all of us were able to have that record? Or if you went somewhere, you can access it and they would know, especially for the providers. If the providers are able to begin to see a longitudinal care, so they don't see you for the first time without knowing what happened in the past. That is really our next horizon, where we could begin to have a unified 360 view across all of healthcare around a patient and around a provider.
Well, I want to thank you once again for joining me on the Slice of Healthcare podcast today. Hopefully, we can have you or someone else on the team on again in the near future. But appreciate your time today, and can't wait to continue the conversation.
I really enjoyed our time today, Jared. I hope it was succinct enough for your listeners, and I appreciate the time. And I hope you have a great afternoon.